So hello guys, welcome to today's class. Hello. Hello guys, so welcome to today's class. We are going to start the FMG Sprint series for orthopedics today. Now without further delay, let's get into the questions, right? So we have now created this program based upon the one-liners, right? We are going to do it as fast as we can, and we are noting the important one-liners as such. Like if you see that question, that particular answer should strike your mind, so that this series of FMG Sprint has been designed that way. So now I have come up with the one liners as the fill in the blanks. So instead of doing the questionnaires, like instead of opting for the options 1 2 3 4 or ABCD, I have done it in the one liner, so that some important concepts will be imprinted in your mind. As soon as you see that question, no, that answer will just flash in your mind. So let's start it like this way. So usually trauma is one such very important thing from orthopedics, and we have various other important topics also, like the tumors, and then we have the metabolic disorders, then we have the joint disorders. So now I have started this session with trauma. So let us first fill this blanks immediately faster, and then we will you discuss the concepts behind it, right? So now let's start with the first question, that is the Gustello-Anderson classification is divides for. So as soon as you see this Gustello-Anderson's classification, you know this is given for the open fractures, right? So what are these open fractures? So these open fractures are such fractures which are communicated to the environment, the open environment, and this environment, when it is exposed, will result in a very important or dreadful complication or the nightmare of the trauma, that is the infection. right? So you have to be careful about these open injuries because we are always worried about the infection. And one more important thing which we are worried about is this, the soft tissue trauma. Soft tissue trauma is one which we are very much worried about in case of the open injuries. So how to deal with such injuries? This Gustillo and Anderson has come up with the classification, right? So as you all know, what is the Gustillo-Anderson classification? It is three types: type 1, type 2, type 3, and type 3 is divided into A, B, and C. Right, and in A you have minimal soft tissue, and then you have B where there is a moderate amount of soft tissue is there, where you need the help of the plastic surgeon, right? And then we have type C, which is dedicated to the vascular injuries, right? So this is the Gustillo-Anderson classification for open fractures. And in this classification it is not very much widely used because of some drawbacks around it, right? It doesn't tell you about how much is the bone, whether you have to go to the amputation, whether you have to, you know, salvage the limb. So there are various other classification which have come up now, but we usually basic from the undergraduate to the postgraduate level or transformation, we fix to this type of classification to decide, you know, just to communicate to others like which type of fracture we are dealing with, right? So now to understand this Gustillo-Anderson classification, so this is the first method where you can learn things like, so this is the type 1 or the grade 1 type of injury where you have the puncture wound which is less than 1 centimeters. So Gustillo-Anderson usually tells you about the length or the size where the fracture is exposed to. So the puncture wound usually less than 1 centimeter. If it is more than 1 centimeter but less than 10 centimeters, it belongs to grade 2, right? And grade 3 is more than 10 centimeters. As we have already discussed, there are 3 in grade, right? In grade 3 is further divided into A, B, and C. And C, you have to remember that it is dedicated to the vascular type of injury. And coming to the B, it is usually the periosteal stripping which you see, and there is a bone exposure. So you have to deal with a plastic surgery type, right? Where you have to cover the bone with the soft tissue, right? And so if you read this way, like puncture wound less than 1 centimeter, minimal contamination, and then minimal soft tissue damage, it usually doesn't sit in your mind, right? So next, how do you deal with such classification? Now we have this tabular form, right? If you see this tabular form, it is little bit well organized, right? So you can first evaluate that this Gustillo-Anderson classification. First you have energy of mechanism, so how the mechanism of injury is occurring. Then you have wound size, then it deals with soft tissue injury, then it deals with contamination, then it deals with comminution and fracture type. So there are various other things which are added to it, but the best way to learn medical subject is by images. Right now, as soon as you see this image on the screen, you know this is type 1, where you just remember that it is 1 centimeter. So obviously there will be minimal contamination, minimal soft tissue. So you can directly go to definitive type of treatment if it is a grade 1 injury. So it is a just a less than 1 centimeter or 1 centimeter type of injury. And coming to grade 2, it is between 1 and 10 centimeters, where you have to evaluate and you have to debride the soft tissue, and if the closure, and if you can close the skin, you can directly go to definitive fixation, right? So this is grade 2, right? And grade 3, by seeing the images, you can remember that. First, let's see that C is vascular injury, as you already know. And then coming to the B, you just remember that B is where the soft tissue is not proper and you require a plastic surgery, where you need a skin grafting, or you need a flap fixation for the bone. So whenever there is a plastic surgery involvement, it is 3B. Without plastic surgery, if you can close the wound, it is 3A, right? So for 3A, 3B, and 3C, you always go for external fixation, right? So you first deal these fractures with external fixation, then first deal with this soft tissue with external fixation, right? And then here in 1 and 2, you can go for a definitive fixation. So what is a definitive fixation? It is nothing but you can directly do the nailing for this fracture. So here it is the tibial fracture. So you can directly go with nailing and close the wound. And here also you can go with a tibia nailing and then close the wound. So this is type 2. But in case of type 2, you have to be careful and you have to put him on antibiotics for a higher number so that you don't we don't result in infection again, right? So hello everybody, Neeraj, this is not recorded, so I'm live here. You can ask any doubts you want. So now I just wanted to take a little bit of time to explain that images work better than words, or tablet form is the medium, like images do the best, then comes the tabular form, then is the notes whatever you write. So always try to write in images form so that it gets imprinted in your bone. Now we have dealt so much with the open fractures, so that is the Gustillo-Anderson classification, right? And now next question. Callus formation is seen in which type of bone healing? So coming to the type of bone healing, so once there is a fracture, now it should heal. So this is nothing but a bone healing, right? As any other tissue, the bone also heals. So there are two types of bone healings you already know. One is by the absolute and then you have the relative way. So this is the absolute stability we are talking about, and here it is the relative stability. So before that you have to understand that there is a primary bone healing and then there is a secondary bone healing, right? So what is a primary bone healing? So primary bone healing is one where there is the involvement of callus, right? And secondary bone healing is one which directly heals. Right, here you have to understand that bone healing is of two types, primary bone healing and secondary bone healing. And here in the absolute stability, there will be no formation of callus, right? And in the relative stability, there will be formation of callus. So where do you opt for this? So relative stability is where you need the callus formation, and usually this is the long bones where we need callus formation for the strength of the bone, right? Such as your femur, then your tibia, these are called the long bones, and then your humerus. So here you go for the relative stability, right, where there is a callus formation which is seen. And then here, so callus formation is seen in which type of bone healing? It is seen in secondary type of bone healing, right? Where you require a large amount of callus for the strength of the bone. So I hope this is clear. So primary and secondary, primary is direct healing, direct contact. Secondary is through callus formation. So where do you see this callus? You see it in the relative stability. So what are the examples of this relative stability? You deal with the nails. Nails when put into the long bones will provide a lot of callus around it. Then it gives this strength, right? Strength to the bone. The third question, optimal strain favoring fracture healing according to Perrin's theory. So here, after understanding the absolute stability and the relative stability, so what are the principles which are governing this absolute and relative healing? So here, the Perrin's, what is this Perrin's theory is, the Perrin's theory has told us that strain around the fracture plays an important role in healing. So strain around the fracture plays an important role in the healing. So you should always maintain low strain. So here you should not always go for high strains or very low strains, but the optimum strain is somewhere between 2 to 10% for the bone to heal. So for absolute fixation, we go somewhere less than 2%, right? So where there is 2 to 10% of strain. So this strain, you need not understand much about it. So here the strain is whatever the fixation we are doing around it, right? So this strain, whatever the fixation we are doing around the bone, should be a minimum of 2 to 10% for the bone to heal. So the optimum strain here would be 2 to 10 percentage, right? Just remember that 2 to 10% is the optimal strain which is required for bone healing, right? And then that is the parents theory. And then what is the Wolff's law? So as you have understood about the strain, now let's understand about the stress. So strain, just remember it is 2 to 10%. Now coming to the stress. So stress when given to the bone at that particular part, this will result in what is called a increased in bone formation. So stress, the bone is formed along the angle or along the way the stress is given to the particular bone. So if this is your femur, so now this is your femur bone, right? And here why is more bone on the lower or the lesser trochanter? So you remember what is femoral calcaire femoral, you know? So that is the a bone with part of the bone which is present around the lesser trochanter, right? So why is that dense bone which is present along the lesser trochanter? Because the weight bearing is for passing through that particular area, right? So the stress which is given there, it has increased the bone formation. So more stress you give to the bone, there is more bone formation. So whenever the compression and tension is given in a particular part of the bone, the bone formation or the endochondral ossification gets increased. So that is the Wolff's law, which is the stress related, and this is the Perrin's strain theory. So remember two, strain theory and stress. Strain is you have to maintain it around 2 to 10%, and stress is the Wolff's law. You give stress or you produce the compression and tension along a particular part of the brain, particular part of the bone. This particular part, there are electric currents which are going through this particular part, which will result in the bone formation, right? So that is the Perrin's theory and the Wolff's law. Next, the components of the lethal triad. So why do you understand why this lethal triad? Mainly you have to understand it for the polytrauma. So what is a lethal triad? So it is nothing but three things which are involved in it. So first, always remember the hypothermia, right? Hypothermia, then it is the coagulopathy, and then you have your metabolic acidosis, right? So these are the three things which are involved in this triad, the lethal triad. So first is the hypothermia, the coagulopathy, and the metabolic acidosis. So what is hypothermia? Whenever there is a decrease in the temperature, this will cause the decrease or halt the coagulation cascade. So the cascade is halted, and then this will result in coagulopathy, right? And then this whenever there is a coagulopathy, it leads to the metabolic acidosis, right? The tissues which is there, they are deprived of the oxygen, and whenever there is no oxygen in the anaerobic condition, it leads to metabolic acidosis, and again this metabolic acidosis will lead to hypothermia. So this is a lethal triad, and you should always be careful that the patient doesn't land up in this triad, so that you may lose the patient in polytrauma cases. So here the lethal triad is the hypothermia, then you have your coagulopathy, and then you have your metabolic acidosis. So you have to always take care of these three conditions so that your patient doesn't land in death, right? Then what is the severe head injury indicated by GCS score of? So you already know what is a GCS. This is Glasgow Coma Score. So this Glasgow Coma Score is E4, V5 and M6, right? So you all know what is E4, V5 and M6. So when I say E4, E is for eye opening, and this is 4, and this is 5, and this is 6. So how do you remember? E4 is you can start with directly with no response, then a response to pain, then to speech, and then spontaneous. So you remember what is 1 and 4. This is easy, right? So first always with speech, right? So we always whenever you go beside the patient, you always try to wake up the patient with your command, right? you command the patient to open the eyes. But if he doesn't open with the command, then you go for stimulus, the pain stimulus. So this is easy to remember, 4 3 2 1. So first 4 is spontaneous, 3 is to speech, and 2 is to pain, that is stimulus, and 1 is no response, right? So that is E4. Then coming to V5. So similarly, just imagine that you're standing near the patient and asking him from what is your name and all. Then he is oriented, you give 5. But he's confused, then you come to 4. But he's not talking properly, there are no sentences but some inappropriate words, then you give 3. Then only sounds, then you go for 2. And if there is no response, then it is 1. So E4, V5 and M6. So this is little bit tricky, the 6th one. So 6, you know, it obeys, like you go to the patient and you tell the flex, or you raise the hand. So if he raises, then it is 6, no doubt in that. Then if he doesn't do it, then you stimulus, then you give the pain stimulus, that you pinch the patient, and with that if he moves, then you give 5. And now if he flexes or withdraws from the pain, then it is 4, right? And you always see extension is little bit easy, right? Extension is where our muscles are at ease, but flexion we require little power for flexion. So first is flexion, that is if he is able to do flex, if he is able to flex, then you give 3, or extension you go for 2, right? And then there is no response, it is. So absolutely, if patient is normal, he gets 15 out of 15. But if it is less than 8, then you say the patient is in coma, that is a severe head injury, and least score is 3, because there is no 0. Always remember, least score is 3, right? So that is how the severe head injury we are going to deal with, that score of 8 or less, right? So this is about the first 5 liners. So just remember Gastrello for open fractures. You remember CE is dedicated for vascular injury. Then there is callus, which is seen in secondary bone healing, and Perrin strain, Wolff's law. We have learned about Wolff's law, and then we have seen what is absolute stability and the relative stability. So just a little moment for this slide. So this, can you somebody name what is, so let me name this as A and this as B, right? So what is A and what is B? Quickly, can somebody answer what is A and what is B? So here the A is absolute stability, where the bone is healing through primary bone healing, right? And then here it is a relative stability which we are providing to the bone, and now this is a secondary bone healing, right? Now it is clear. Now absolute is where there is no gap between the fracture, and now the fracture is fixed end to end. There is no gap, or there is no space for callus to form, right? Direct ossification of the bone occurs, right? Now here when it comes to B, here you see there is a gap. Now you are leaving some gap in the fracture side, so that there is a callus formation, which is required for the long bones, because there has to be strength in the long bone. Just remember absolute stability, relative, primary bone healing, and secondary bone healing, right? That much is enough for this slide. Now next, mainstay of treatment for midshaft closed clavicle fractures. So what is the mainstay for the clavicle fractures? So usually clavicle is a non-weight bearing bone, right? So it does not bear any weight, but this is an important bone for transmission of your axial weight onto the appendicular skeleton, right? So the only bone which is connecting your axial to the appendicular skeleton is the clavicle. But please remember, clavicle usually get fractures in the middle tooth, that medial 2/3 and the lateral 1/3, so mid shaft fractures, and usually this mid fractures can be treated conservatively. So you have to treat them not with your plates or nails or surgery fixation. You have to give them rest. So rest is by splinting, and this splint will cause immobilization of the fracture fragment, and further they heal. So usually the mid-shaft clavicle fractures are dealt with splint. So you can give a figure of 8 bandage, or you can just treat them with the arm pouch. That is how they they get healed. But remember, whenever there is a tenting of the skin or there is a large gap between the fragments, then you have to go for fixation, right? So usually we do a plating of the clavicle. So clavicular plating is done. So the conditions of that plating are whenever the gap is more or whenever there is a tenting of the skin. So the impending skin necrosis. So whenever the sharp fragments are coming out. So even in case of open fractures, you go for clavicular plating, right? Now, next, the classification used for proximal humerus fracture. So these are one of the, straight questions. You need not think much. You should revise them repeatedly. So here the answer is Neer classification, right? So Neer's classification has divided the proximal humerus four parts, and this is called a four part, one part, two part, three part, four part. So now this classification is nothing but your Neer's classification used for your proximal humerus, right? Then luxatio erratica. This is also a one liner. What is a luxatio erratica? It is nothing but your inferior shoulder dislocations. So if you remember the shoulder dislocations, the anterior shoulder, posterior, and then there is an inferior shoulder dislocation. So what is so special about this? So this inferior shoulder dislocation is not a usual type, right? This is a rare injury, and here typically you see that the patient presenting with the abducted hand, so abducted limb, it is fixed in abduction. So whenever the patient comes with abducted limb, you have to suspect a inferior shoulder dislocation. A special name is given to it. It is called luxatio erratica. But then what is the most common type of shoulder dislocation? The most common type is your anterior shoulder dislocation. The most common is your anterior shoulder dislocation, right? And in the hip, which is the most common? In the hip, the most common in case of hip is your posterior hip dislocation, right? So these are important one liners again. So again, the most common joint to dislocate is your shoulder. In spite of enjoying the freedom, that is 360 degrees freedom, this is the most common joint which is to be dislocated, and in that the most common type is your anterior shoulder dislocation. Coming to the hip, it is most common is your posterior shoulder dislocation, right? So, and luxatio erratica is your inferior shoulder dislocation. What is so special about it? It is very rare, and you see the limb, the patient present with your abducted hand, right? So this is the clue for your inferior shoulder dislocation, right? Now, having understood that Neer is the proximal humerus, now let us understand few other classification, because this little bit easy and it will save your time in the exam if these questions appear in the exam. So you already know proximal humerus is Neer. Then there is femoral head. Femoral head is your Pipkin's classification. Pipkin's classification for femoral head, and this is usually applied in case of dislocation. So whenever there is a fracture dislocation, then you use this name, that is Pipkin's classification, right? And then you have acetabulum. Acetabulum is lateral and Judet. Lateral and Judet classification is for acetabulum. So acetabulum fractures are also most common, and you usually see the posterior wall which are common, and the posterior wall and posterior column are usually more common in case of your acetabulum, right? Right, so that is Lieutenant and Judet classification, right? And then what is Monteggia? Monteggia is Bedo classification. Monteggia, Bedo classification is used for Monteggia. Then supracondylar humerus. This is supracondylar humerus in case of pediatric population. That is the famous Gartland's classification, which is used. So Gartland classification is one such classification which only three types. So displaced, undisplaced one, mildly displaced, and completely displaced. It is very easy, type A, B, and C. That is Gartland's, that is supracondylar. Then calcaneum, you have two. One is Essex Lopresti classification, and the commonly used is the Sanders classification. But Sanders, please remember, it is a CT classification where you need a CT scan to classify it. On the X-ray, if you want to do it, it is Essex Lopresti. Essex Lopresti classification, right? So that is for calcaneum. Then for the femur neck, this is your favorite femur neck. You have three. One is the anatomical classification, then you know there is a Powell's classification, and then you have your Gardner's classification, right? So these are the three classifications which are available for your femur neck fractures. So what is Powell's classification? So based upon the degrees 30, 50 and 70 degrees. So this is the femoral neck classification. So as the angle increases, the whatever the forces which are acting to the fracture will become shear fracture. So shear is somewhat which is not stable, so now it becomes more unstable. If the angle is 30 degrees, it is considered as a stable, and if it goes to 70, it is considered as unstable, because the forces now acting at the 70 degrees are shear forces. These forces are very abnormal forces, and usually they don't do any good to the fracture, right? So these are very bad shear forces. So 70 degrees is an unstable fracture, right? Then the lateral condyle of humerus. Lateral condyle of humerus is the Milch classification. So it is little bit hard, but please write it on a paper and stick it to the wall and daily read it at least once, so that in the exam you have to just mark it in a just a click of the question. Like if you see Montegia, directly you go to the Bedo classification. If you see supracondylar, Gatland, and then calcaneum, Sanders. Femoral neck, you all know, and then lateral condylar is Milch classification. So that is it about the classifications, the important ones which I picked up. And then what is Holstein-Lewis fracture? So this is somewhat very, favorite questions of the examiners. So whenever there is a fracture humerus at the junction of middle to distal third, and here what happens, why has this gained so much of popularity? Because of the radial nerve injury. So if you remember the course of the radial nerve in case of up arm, so this, it passes through the radial groove and now it tries to pierce into the lateral intermuscular septum near this junction of middle and distal, right? So this middle and the distal third junction, where now this radial nerve is trying to pierce the lateral intermuscular septum, here if there is a fracture that is occurring, and now this radial nerve gets trapped between the two fragments, now that is called the Holstein-Lewis fracture, right? So the name given to it is a typical name. So you have to understand that this is a humerus fracture. So Holstein-Lewis has no connection with humerus and radial nerve in any of its name when you hear it. But you have to remember that it is a humerus with a radial nerve injury. That is your Holstein-Lewis fracture, right? And then what are the components of the terrible triad injury? So terrible triad injury is of the elbow. So triad is nothing but three components, right? So you have to have three components in it. So the first one is your elbow dislocation. So in the elbow, the main culprit for the terrible triad is elbow dislocation, and then you have your radial head fracture, right? And then the most important is your coronoid fracture, right? So whenever there are these three fractures evidently seen on the x-ray, that means it is a terrible triad. So why are you worried? Because it needs a very judicious plan of treatment, right? So here is the image for you to better, for you all to remember it in a better way. So here there is an elbow dislocation where you can see on the x-ray. So this is the elbow dislocation, and then there is a fractured radial head here, and then you have your coronoid. This is your coronoid. So usually the coronoid is one which protects your elbow. So now this is your elbow and this is your coronoid. Yeah, this is your coronoid, right? And now if this is the fracture, which is the coronoid has coronoid fracture has occurred here, and this will result in more instability of the elbow, right? So this coronoid gives some amount of stability to the elbow, anterior stability, right? So now whenever there is a fracture of the head with the coronoid fracture, this results in the dislocation of the elbow. Three put together is nothing but your terrible triad of elbow. Now to understand this, just imagine elbow sitting in, that is the olecranon fossa, and then what is the one important structure which is protecting it is the coronoid on the anterior aspect, right? So now you have to tell the worst form of elbow dislocation. That is the anterior, that is the coronoid has damaged, the radial head has damaged, and the elbow is dislocated. So there is a lot of ligamentous injury occurring over that particular area, that is around the elbow. Hence, it is named as your terrible triad. So please remember these three things. Usually we remember elbow dislocations and the radial head. We tend to forget this coronoid fracture. This is what you have to remember. That is the coronoid fracture. Now, once you have understood that important condition in elbow, now let's move on to the next question. Radial head dislocation plus interosseous membrane disruption plus DRUJ dislocation is called. So there is a radial head, and that means there is a proximal injury, and then there is interosseous membrane injury, and then there is a distal injury, right? So the proximal and the distal, if you imagine your forearm, there are proximal radioulnar joint, distal radioulnar joint with the interosseous membrane in between. Just imagine the forearm in your brain, and now there is a proximal distal with the disruption of the interosseous membrane. This is somewhat very highly, it should happen only with the high velocity, and the name given to this is your SX lopricity, right? So this is your SX lopricity injury. So this is one form which you have to diagnose it. So it requires again planning and treatment. This is your SX lopricity. So for your better understanding, again I have come up with an image. Remember, this is your proximal ulna, your ulna, proximal radioulnar joint, and your distal radioulnar joint, and there is an injury which is passing from the proximal to distal. So what is the way from it is passing? It is passing through your interosseous membrane, where there is a tear in the interosseous membrane. So as soon as you see the X-ray, so first you will see there is a radial head fracture, right? And then you have to evaluate for the elbow. So if it is an elbow dislocation with the radial head and the coronoid, then you will name it as terrible triad. But now when you come to the distal part and you see there is some disruption in the DRUJ, and now you have now in your mind there is something which is telling you that if the distal and the proximal is involved, you have to check for the interosseous membrane too. And if you see that some abnormality is there in interosseous membrane, the gap is increased or something on the X-ray, then you have to always be suspicious about this SX setting. So that is why you will have to remember that you have in orthopedics always you have to get one joint above image and one joint below. So here, if somebody is telling you there is a pain in the forearm, always evaluate for elbow joint and make sure that you're also evaluating the wrist. So one joint above, one joint below, and in two planes you have to go for AP view and the lateral view in case of forearm, right? Similarly, you have to evaluate for AP view and the axillary view in the case of shoulder. So like that, you have to evaluate them in two planes, right? So two views, two planes, right? So that is the rule of orthopedic. So here if you miss, so you have just seen the elbow joint and you've seen radial head, and you tell the patient that it is a radial head injury, right? And as you have missed this wrist joint, just remember how how difficult for the patient, you have, then they come up with pain in the wrist, and then you take the X-ray, and then you evaluate for a sex lopricity. By the time the injury would have been very high, right? By the time the damage which happened to the joint will be very high. So we have to always be suspicious and always evaluate for one joint above and one joint below, and always include two joints in your evaluation, right? At least two joints should be evaluated, right? So this is your SX lopricity. And like somebody can please tell me the similar of your in the lower limb. So this is the upper limb of SX lopricity. Similarly, in the lower limb, we have what is called as mesonevis fracture, right? Mesonevis also, where you see there is a ankle fracture, and now this fracture gets impacted, and now you will find there is a fibula fracture in the proximal end. So distal you have ankle, and proximal you have your fibula fracture. So this is your mesonevis fracture in case of your lower limb, and SX lopricity in case of your upper limb, right? So that is about the this one liners, right? Now we are going to the next set. So what is the nightstick fracture? So faster, nightstick fracture is nothing but a isolated ulnar fracture, and usually these fractures are of a low velocity where somebody puts the hand just to defend themselves, right? So a simple fracture, isolated ulnar fracture, usually in the mid shaft, is called as a nightstick fracture, because usually whenever the policeman at the night time tends to beat us or beat any human being, they tend to put the hand. So this fracture pattern from here to here, anywhere an isolated ulnar fracture, is nothing but your nightstick fracture. Again, you have to remember, because nightstick, you have no clue anything in the ulnar there, right? So you have to know that a nightstick fracture is an isolated ulnar fracture. Now coming to the Colles fracture. Everybody knows what is Colles fracture, right? You know that it is a distal radius fracture, usually seen in old age and all. But what you have to remember is what are the components of Colles fracture, because knowing up to Colles fracture is up to your UG theory. Now you're preparing for your FMGE, like you're giving a test where you are to completely know about everything, right? So what are the components of Colles fracture? So please remember, Colles fracture is a distal radius, and main important thing you have to remember is it is an extra articular fracture, right? So that is why we are treating it with casing first, and then if it is not if it is extending into the joint, then you go for plating, right? So this is an extra articular fracture. So here in this extra articular fracture, what is mainly important in the Colles is you have to describe about the displacement of the distal fragment will decide the type of the fracture, right? So when this displacement is a dorsal displacement, then you call it as a Colles, right? So somebody is asking Colles, don't just say it is a distal radius fracture. No, you have to tell precisely that this is an extra-articular fracture of the distal radius where the fragment displaces dorsally, and then you name this as Colles fracture. And usually these fractures are seen in osteoporotic women, right? So in a older age women which they fallen outstretched hand, then you result in this Colles fracture. So only dorsal displacement is called Colles fracture, or you have something else. So there are 6 components where you can see. So first one is impaction. So whenever there is a distal radius extra-articular fracture with impaction, you still call it as Colles. And then you have dorsal displacement, and you have, as I have already told you, then you have dorsal tilt, simple the tilt, and lateral displacement and lateral tilt. And then if you have a supination form of injury, then it is also a Colles. So these are the displacement or the components of the Colles fracture which you have to remember and evaluate on the x-ray. So whenever there is a lateral displacement or lateral tilt extra-articular form, then it is also a Colles, and if it is a supination form of injury, then it is also a Colles fracture, right? So what is the opposite of dorsal? This also, you know, the opposite of dorsal is nothing but your volar or ventral or palmar. So that is your Smith fracture. So Smith fracture is your volar displacement of the fracture. So dorsal and volar, whenever there is a volar displacement, it is a Smith fracture. Dorsal displacement is your Colles fracture. Then what is the intra-articular fracture? Now I told you it is an extra-articular. Then what is an intra-articular fracture? So here the intra-articular fracture is nothing but your Barton's fracture. So this Barton's again can be a dorsal Barton or a volar Barton, right? So extra-articular, Colles, intra-articular, Barton's. Again, Barton's can be a dorsal Barton's or a volar Barton's, right? That is about the fractures around the distal radius. Next, tenderness for scaphoid fracture. So this is one of the important fracture which is usually missed even by the famous surgeons, right? Famous of surgeons usually miss, right? So scaphoid is one such fracture which you have to always be suspicious about. So whenever a person is complaining about the wrist pain, and now you want to evaluate for the scaphoid fracture, where do you usually look for it? So that is the area that I'm asking for. So that area is your anatomical snuff box. Now you have to understand what is anatomical snuff box, and there you will elicit the tenderness. Once the patient is having tenderness in the anatomical snuff box, that is an indication for a probable scaphoid fracture. Then you have to evaluate with the radiological investigation, that is the X-ray, and you take this X-ray in again two views, that is the oblique view or the scaphoid view, where you see the scaphoid fracture, right? And you have to be very careful about this scaphoid fracture because this is the bone which usually prones for AVN, right? So the scaphoid is the one such bone which might result in avascular of necrosis. Hence, to prevent this complication, you have to always be suspicious of the scaphoid fractures, usually whenever the patient presents with a trauma and a wrist injury, right? So whenever the patient presents with trauma with the wrist injury, you evaluate for the tenderness in where this is your anatomical snuff box. So this area is the anatomical snuff box. You can see clearly there is a depression, right? So this depression is nothing but your anatomical snuff box, and you evaluate tenderness in that particular area for scaphoid fractures. Next, what is the fracture of the fifth metacarpal is called? This also, you know, these some fractures are named fractures like the nightstick fractures. So here the metacarpal fracture. So this is the fifth metacarpal. So this is the fifth metacarpal that is near the ulna side. And now this neck, whenever there is a neck fracture of the fifth, usually we do a fist and then we try to hit it, right? So making a fist and hitting is usually seen in boxing, right? So there, this is so hence termed as the boxer's fracture. So that is boxer's fracture, that is the neck of fifth metacarpal, right? What is the sign which is seen in scapholunate dislocation? So whenever there is a scapholunate dislocation, so now we have come up to the carpal bones, right? So in the carpal bones, you know that the wrist joint is associated with the scaphoid and then to lunate. So there is a scaphoid fossa and then is a lunate fossa in the distal radius, right? So this scaphoid and lunate, they get disassociated. So these two are interconnected with various ligaments in between them, and whenever there is a disassociation of this two, that is, remember these two are like this and now they have got separated. So there is a gap in this, right? So what is that sign called? So this is nothing but your Terry Thomas sign. So Terry Thomas sign is nothing but there are two instances of this Terry Thomas, the person, and now whenever they get there is a gap in this two that was seen clearly on the Terry Thomas teeth, right? The gap between the two incisors are now related to this scaphoid and lunate disassociation, hence it is as the Terry Thomas sign, right? And that is about the scaphoid and then the important points in the carpal bones, right? Now the important one, this is again important question, base of the first metacarpal. So base of the first is nothing but your thumb. So they are asking about the thumb fractures. So what are the two important fractures in the thumb, you remember? So one is the Bennett's and the second one is Rolando. So these two, lot of confusion again. What is Bennett's, what is Rolando's? Please don't get confused. There is an easy trick for you, and here goes the easy trick. So B is Bennett's, B is for bi. What is bi? Means two. So Bennett's is a two-part fracture, right? So once I say this is a two-part, then this Rolando automatically falls into three-part. So whenever it is a three-part, you can comment them as a T or a Y. So this is a T or a Y shape, that is Rolando. It is a bifracture, that is Bennett's. For B for bi, bi is two, binary system. You remember two. So two, right? And then this is a two-part fracture. So this is a two-part fracture, and the third one is the Rolando, that is a type T or Y, that is a three-part Rolando. Now let us see some of the images. So I have already told you that image is the most powerful form of memory. So this is the image, now I'm showing it. So I have already explained everything in detail, right? So as you see the images, just memorize that. The first one is here on the left side is the dorsal fracture, right? So there is a dorsal displacement, so you can remember that it is going up like that. So that is dorsal, and opposite to is the ventral part, that is the Smith's fracture. So dorsal Colles and ventral is Smith's, right? And when I say it is intra-articular, so now you see these Colles and Smith's are extra-articular, they're little away from the articular surface. So this is the articular surface, the distal radius, now this is the articular surface, right? So now this articular surface Now, whenever it is away from, it is called extra-articular. Whenever it involves this articular surface, it is called intra-articular. So, intra-articular is Barton's fracture. Again, whenever the fragment is on the dorsal aspect, you call it as dorsal Barton's. And whenever the fragment is on the ventral, you call it as a ventral Barton. So, that is what I wanted to explain in 1, 2, 3 and 4. So upper is dorsal, lower is ventral. Similarly, now dorsal is Colles, extra-articular, dorsal, Colles, extra-articular, ventral, Smiths. And Barton's is intra-articular. You see there is extension into the articular part, right? Extension into the joint. So whenever there is a dorsal fragment, dorsal Barton's, ventral fragment, ventral Barton's. So easy, right? Understood about the wrist fractures. Now see this hand x-ray here. The hand x-ray here you can see that there is a fracture in the fifth metacarpal. So this is first metacarpal, that is your thumb, second, third, fourth and fifth. And you already know these are the bases of the metacarpal, these are the heads of the metacarpal, and this is the area of necks, right? And this is the shaft part. So now the neck, fifth metacarpal is your boxer's fracture. No doubt in that. You hope you're all understanding. And now what is this image? This image I have already told you that this distal radius is associated with scaphoid on lunate. So there is a scaphoid fossa, there is a lunate fossa which accommodates these two carpal bones, and now because of the injury, because of the tear of the ligaments, now there is a gap between scaphoid and lunate, and this gap is nothing but your Terry-Thomas sign. So Terry-Thomas sign or scapholunate dissociation. So this is scapholunate dissociation which is seen on the image. Now let us understand the thumb. So this is your thumb and the base of the thumb. Now I am talking about the base of the thumb. So this area is your base of the thumb. So this is your base of the thumb. And here if you see a two-part fracture, we know that is B is for bi, right? B is for bi. That means 2. So this is a two-part fracture. And once it is 2, you know there is a 3, right? 3-part fracture or T-shaped or a Y-shaped fracture. So this is Rolando. So which one is important here? The Bennett's or Rolando? So according to the signs, that is there is one muscle which is attached to this part, right? So this is the muscle, that is your abductor pollicis longus, right? So this is the one which is attached here, and now this will keep pulling your the fragment. So whenever there is a pulling of the fragment, now there will be no union of this particular part. Now remember, both of these are intra-articular. Both of these fractures, thumb base, are intra-articular fractures, right? Both of these are intra-articular fractures. So one is 2-part and the second one is the 3-part. Which one is most important for us? Because this is already comminuted intra-articular fractures. Usually this tends to heal. But here it is a shear force which is acting. As I've already told you that shear is a very bad forces, and this shear force tend to always displace the fragments. Now you have to be very sure that this shear is converted into compressive force, right? How do you do that? Now you try to fix these two fragments. You will fix them. Hence you will convert the shear into compressive force, right? So why it is being converted into shear forces? Because there is a constant pull of the muscle. Because of the constant pull of the muscle, the forces are acting at a high value where there is where the union becomes difficult for the fracture fragments, right? So that is about your Bennett's and Rolando. Please remember that Bennett's is 2 and Rolando is 3. Okay, now we are done with that carpals, metacarpals, hand. Now let's see about the pelvis and the acetabulum. So here in the pelvis, you very well know that you can imagine pelvis. There are two innominate bones, that is the ilium, ischium and pubis. They form together a round structure which is called pelvis. And whenever we are dealing with pelvis fracture, what you have to remember is whether that is a stable fracture or unstable fracture, whether it is stable rotationally or unstable rotationally. So usually they divide according to tile classification, right? Young and Burgess classification. These two are the classification which are used for pelvis and acetabulum. So pelvis and not acetabulum, pelvis. Acetabulum is lateral and judate. Pelvis you can use tile classification or Young and Burgess classification where they usually want to tell you whether it is a stable or unstable fracture, right? If it is stable, whether it is rotationally stable or rotationally, right? So that you have to see first. You see a fracture, you have to evaluate for the what are the various fracture which have happened, whether these fractures are stable or this might result in a instability or instability in rotations, right? So for that, let's see the first one. So the vertical iliac fracture with SI joint dislocation. So a specific name is given to this particular fracture. This is called the crescent fracture. So crescent fracture, just imagine, or after this class just see on the net that the vertical iliac fracture plus SI joint dislocation. So whenever there is SI joint dislocation, now this pelvis, if you imagine this as a pelvis like this, just imagine this, my fingers are the SI joint and this is your pubic symphysis, right? And now the SI joint has been ruptured and it's moved above. So this movement of SI joint above, the dislocation of the SI joint along with the iliac fracture. So now this complete hand is my iliac fracture. So here there is a fracture and now because of that there is a disruption and the SI joint has moved up, right? So this is called the crescent fracture. Sometimes there will be an hemipelvis. So complete the posterior aspect and the anterior aspect you will have fracture. So that is a Malgagni fracture. So ipsilateral side, both anterior and the posterior fractures are equal. It is called Malgagni, and only isolated iliac wing fractures is called Duvernay's fracture. Right? So straddle fractures as contralateral. So ipsilateral is Malgagni, contralateral is straddle fracture, right? So these are the types of fracture which you have to remember. So crescent, that is SI joint dislocation. Malgagni is ipsilateral, both anterior part and the posterior part is damaged, and if that anterior and posterior are opposite to each other, so it on one hemipelvis it is the pubic symphysis or the rami which is damaged, and on the posterior aspect it is the SI joint, so it is the opposite, that is contralateral side, that is the straddle fracture. Or if it is on the same side, that is the SI joint on the same side and the pubic rami is on the same side, then it is your Malgagni, and isolated iliac wing fractures is your Duvernay's fracture, right? Next, immediate and then now this is the crescent fracture we have already understood. Next, immediate treatment for an open book pelvic fracture is. So this is one of the important questions usually asked in the competitive exams. So what is this open book pelvic fracture? So open book is whenever there is a the joint, that is the ligaments between the complete round of the pelvis is lost, the pelvis becomes like an open book. So this open book should be closed now. So usually a pelvis is a closed ring, so there is break chain in one particular ring, now it becomes open, now you have to close it. So how do you do that? Usually you do this immediate treatment with the pelvic binder in the emergency department itself. So this pelvic binder, when you attach it to the pelvis, you are completing the ring again, closing the ring again. So there are various vascular injuries which occur during the pelvic, and they tend to bleed. So this bleeding may result in hypovolemic shock, and now we may lose the patient. By applying this pelvic binders, you might control this bleeding, and then you may buy some time for resuscitation of the patient, and then you may actually give life to the patient, right? So that immediate treatment which you have to always remember when dealing with the open book is the pelvic binders, right? The pelvic binders applied at the level of GT, that is you have to identify the GT, and at the level of GT, that the GT be involved in that bind, right? So now this will close the pelvis and again result in a closed ring. Okay, this I think you can answer. What is the classification used for acetabular fractures is again Letourneur and Judet classification, right? This is Letourneur and Judet classification, right? Next, father attitude. So this is very important. So there are two types, Faber and father. So what are this Faber and Fadir? As this is a rapid revision, I think you all know what is Faber and Fadir is flexion, abduction, external rotation, flexion, adduction, and internal rotation. So this attitude is seen in most important question, that is the posterior dislocation of hip. You have to be very familiar with posterior dislocation of the hip and the father, right? right? And then neck of the femur fracture, sorry, father attitude is seen in posterior dislocation of the hip, right? And this father, and where do you see this Faber then? Faber is usually seen in your IC fractures or your IT fractures. So as soon as the patient arrives, as soon as the patient arrives to the ER department, you can actually tell the patient whether he's having dislocation or a fracture based upon the attitude of the limb. So what is this attitude of the limb? It is nothing but the position of the ease. So whenever the patient has some problem, he identifies a position where it is comfortable for him. For such positions, such positions also give us a lot of clue for the diagnosis. So for one such position is the posterior dislocation of the hip. So in this particular dislocation where the femoral head goes into posterior position, it goes posteriorly, and now this results in what is called as father, that is flexion, adduction, and internal rotation. So once if you see this attitude, you will never forget it. So once if you see this attitude in the emergency and now you the x-ray, you very well, it will get imprinted in your mind that this we are dealing with the posterior dislocation of hip, right? And then comes the next question, that is vascular injury is relatively common in what type of hip dislocation, right? So it is the anterior dislocation, which is the most common type where you see the vascular injury. And then what is most common in the posterior hip dislocation? The most common complication is the sciatic nerve. The most common complication is the sciatic nerve injury. But in case of anterior dislocation, the most common is the vascular injury. So this two you have to remember, and this might be asked. Will get they ask in your exam. That is the vascular injury is most common in case of anterior dislocation, and posterior dislocation it is sciatic nerve injury, which is most, right? And this thing you all can answer. Neck of femur fracture with the fracture line of inclination, that is 40 degrees, is which type of Powell's? So we already know that the Powell's based upon the inclination. So you will draw the fracture line and now you connect it to the horizontal of the head, right? So this horizontal of the head, if it is 30 degrees, and then Powell has tell this is 50 and this is 70, right? So as the angle increases, the shear forces increase, right? As the angle increases, the shear forces increases and it becomes unstable. So when you say it is 40 degrees, it is somewhere in B, right? Powell type B, where it is 30 to 50 degrees. This is less than 30 degrees and this is more than 70, right? So that is about the Powell's classification in case of femoral neck. Now, next, common complication in an intertrochanteric fracture femur. So now I have already told you that there is an IC and IT fracture. These are the fractures of neck of the femurs, right? So neck of the femurs, you have two important types, that is IC and IT. One is intracapsular and one is intertrochanteric. So in case of intertrochanteric, what is the most common complication? So usually these tend to go into malunion, right? IT fractures, they usually go into what is called as malunion, whereas IC fractures, they go into non-union. So here the answer would be malunion in case of your IT fractures, where if the similar question was IC fracture, then it goes into non-union. So again, what are the causes of this? So non-union, why? And why a malunion? So non-union is one where because of the intracapsular, like it is inside the joint. So inside the joint you will have this synovial fluid, right? So this synovial fluid has some inhibition on the union, hence the IC fractures tend to go into non-union, and the IT fractures, that is the they are occurring at the junction of intertrochanteric region, that is between LT and GT, right? So this is extracapsular, so there is no capsule around it. So there is a union which is occurring, but usually they tend to result in malunion if they're not treated properly. So that is one of the important complication of IT fracture. Next, let us see some of the important fracture complications, right? Most important one, and this, please put 100 star marks around it, because I have not seen a exam where this question has not been there, right? This is very, very, very important question, and you read everything about this and you're sure that this question will be there in the exam. So one such question is, the patient with femur shaft fracture develops rash and becomes irritable. What is the diagnosis? Very quickly, everybody just shout it as fat embolism. Right? So the fat embolism is the answer for it. And here, what are the clues which you have to tell it as a fat embolism? So first, it is a femur shaft fracture, right? And usually this shaft fractures will be seen in young males. So that is also one more clue. So whenever you want to answer the answer, whenever you want to diagnose a condition with fat embolism, look for the clues, right? So first, it is a young and a male with a femur shaft fracture, right? And then he will suddenly develop third or fifth day, suddenly develops what is called as rash, or he develops SOB, that is shortness of breath, and becomes irritable, right? So these are the signs where the pulmonary complication, neurological complication, and the skin, that is rash, is seen. All put together is fat embolism, right? So you have to be right for this question, because there is no go for it. It is a PYQ. It is a very favorite MCQ, right? The fat embolism. Fine. So that is about the fat embolism. Next question. Flexion of fingers with extension of wrist is Workman's sign, right? So what is a Workman's sign? So here you have to understand one important thing. There are two important syndromes which you have to understand. So one is the very, very important compartment syndrome, right? So what you have to understand of this, so when we talk about compartment syndrome, just imagine that the limbs, so whenever there are this appendicular skeleton, the appendicular skeleton is one where you see the limbs, right? The upper limbs and lower limbs, and here they are enclosed in a compartment. So the muscles which are put these limbs are by the compartment, right? The center one is occupied by the bone in case of your thigh, or in, if let's take the example of leg, where you see two bones, that is tibia and the fibula, right? So tibia and the fibula are there, and now you are being divided this into two compartments, right? So now this compartment is, so it has been divided like this. So this becomes your anterior, the posterior, and the lateral compartment, right? So now I'm taking typical example of the leg, and now you have all these structures of the compartment, like it is divided into anterior, posterior, and the lateral compartment, right? So there are muscles embedded in this compartment, like anterior, posterior, and lateral. So what is the important structure which is dividing it all? So please remember that important structure is nothing but the fascia. So fascia is one tough fibrous tissue, right? Tough fibrous tissue which is enclosing this compartment. So now this fascia, there is an anterior which is present, the fascia around the anterior aspect, the fascia around posterior, and there's a fascia on the lateral, like that it is. And this is a very tough structure. Because of this fascia, now these are filled into compartments. Now here, whenever there is an increase in the pressure, so now there is an injury to it, and now there is an increase in the pressure, and there is no way for letting out this pressure, right? So now the pressure of this compartment has been raised, which is more than 30 mm of Hg. So whenever there is a rise of this pressure, and what will happen? What is the fluid mechanics? Simple mechanics. Fluid usually follows from high pressure to low pressure. Now the vascular supply to it, the vascular supply to it gets decreased, because already there is high pressure. So because of the high pressure, the fluid or the blood cannot enter into it, right? So now the vascular supply is decreased, and hence these whatever the muscles inside this compartment now are devoid of the arterial supply. So whenever there is arterial supply is decreased, the oxygen is decreased to this muscle, right? Now the compartment will lead an anaerobic mechanisms, right? Anaerobic mechanisms, again there is production of acidosis there. Again there will be edema, necrosis. So this necrosis, edema again will increase the compartment pressure, and because of this pressure again there will be further decrease in the vascular supply. And now all the muscles slowly they tend to disease, they tend to necrose, and once the muscle is lost, it is lost forever. We can't recover the muscle, right? So once the myonecrosis has occurred, it is permanent. Now this is the point where you have to intervene, and now you try to reduce this pressure. So how do you try to reduce the pressure? So you already know that what is the one tough structure which we are dealing with, it one tough structure which is causing all this, so fascia. So you will go for fasciotomy. Now you cut open this fascia so that the pressure is relieved. Now you will save the muscles, right? So this is the compartment syndrome. Now, so you know what are the signs and symptoms of compartment syndrome. I don't think it is I need to explain you all. So once the vascular supply is down, then patient will have pain, pulselessness, paresthesias, and all the things. But what you have to remember is the important point here is pain very, very, very high, out of proportion to the analgesic. So how much of analgesics you dump into the patients, he still has pain, and that is where you have to suspect that now we are going to deal with right, and now you have to get ready to do the fasciotomy, right? So that is the whole little or the vicious cycle where the compartments enter into, right? So that is the compartment syndrome. Now let us imagine that we are dealing with compartment, and now we have forgot that this is compartment and all, and patient is crying with pain, and now you're giving him analgesic sky, and whole of the thing has happened here. And one fine day now the patient comes with an important sequelae of this compartment syndrome. What is that important sequelae? Workman's ischemic contracture is VIC. That is because of all the muscles, the flexors muscles, which have been necrosed. Now this results in what is called as VIC, Workman's ischemic. Sure. In this contracture, because of the muscles get contracted, you will find the flexion of the fingers, and now the wrist goes into flexion. And once you try to extend the once you try to extend the wrist, they will go into flexion, and once you try to flex it, they slowly relax the muscle so that the fingers go into extension, right? So that is the sign. So flexion of the fingers. So and now you tend to extend the wrist, now the fingers go into flexion. Because of this, muscles get contracted, they have become small, the length has become small, so now they can't flex your fingers. The only that whenever they want to extend is you have to flex the wrist, so the opposite movement will occur, that is the extend fingers. So this is the Workman's ischemic contracture, and this is called the Workman's sign, right? So that is the story behind the compartment syndrome. And now let us go to one more important syndrome, that is your crush syndrome. So in this crush syndrome, what happens? Crush syndrome is also similarly. So here the compartment syndrome is, it could be various reasons for compartment syndrome. It could be the fracture, or it could be a tight plasters around it, or it could be because of the poisoning and various other treatment, various other causes for your compartment syndrome. But the crush syndrome is one syndrome where you see that the fracture. So here let us understand what is the crush syndrome. So here what happens is the muscles are completely crushed. That is because of the high velocity of injury which has occurred to the patient. And because of this high velocity of injury, the muscles get crushed, and there are various sequelae of this crush syndrome. So the first one being the hypovolemic shock, because there is lot amount of fluid which has been lost. And the second one is myoglobin which is released, so this will result in myoglobinuria, right? So this myoglobinuria will enter into the kidneys, and this is toxic, and it results in what is called as acute renal failure, right? And this acute renal failure is because of your tubular necrosis. right? So the proximal tubule, whatever the PCT is there, it is very much of very sensitive. So this results in tubular necrosis, right? And it results in acute renal failure. So these two important things which you have to remember about the crush syndrome is that because of the heavy damage to the muscles, it results in release of myoglobin, and because of heavy injury, that is because of lot of losses, the patient will land up in hypovolemic shock. And next is the lactic acidosis. So here again they because of again the same mechanism, he will land up in lactic acidosis, right? And then various abnormalities, that is the hyperkalemia, because again there will be an increase in the muscle mass. So because of the damage of the muscle mass, all these myoglobin, potassium are released, because potassium, muscles are rich in potassium. So this myoglobin and this potassium is released, and this will result in what is called as hyperkalemia, myoglobinuria, myoglobinemia, and then your shock. So these are the sequelae of your crush syndrome. So what was the question asked here? So the question was, what is the electrolyte abnormalities usually we see? So we usually tend to see hyperkalemia. So the abnormalities are, first there is myoglobinuria, and then there is lactic acidosis, hypovolemic shock, and there is hyperkalemia or ventricular fibrillation. So these are the consequences which we see in case of your crush syndrome. So that is the about the trauma. And now let us read some of the important eponyms of the fracture. So once you see the name of the fracture, you have to tell which part it is involved in, right? So march fracture, what is a march fracture? So this is very commonly asked in orthopedics, like it can be asked as, you know, match the following also. Like let us read about some of the important things here. So what is a march fracture? A march fracture is fracture second metatarsal, right? Fracture of the second metatarsal is a march fracture, usually seen in case of soldiers going for marching, right? So young soldiers which have recently joined because this is what this is an example of a stress fracture, right? So this is march fracture. And then what is a die punch fracture? This is again related to the lunate fracture. So whatever the lunate, it goes into depression, that is a the lunate fossa, it goes into the dislocation, that is a die punch is associated with the lunate fracture. Then you have bumper fracture, which is a lateral condylar fracture of tibia. So the lateral condylar fracture tibia is the bumpers fracture. Then you have Schoffer's, it is radial styloid fracture, right? And then you have Pott's fracture, this you all know, it is bimalleolar. And then you have your Cotton's, it is your trimalleolar fracture. And then you have Aviator's, it is talus fracture. And Chopard's is again a mid-tarsal, that is your calcaneum with your cuboid, and your with talus with your navicular. So talonavicular with calcaneocuboid is called is your Chopard's fracture. Then what is Lisfranc's? Lisfranc's is tarso-metatarsal. So the junction of tarsals or with the metatarsals is the Lisfranc's area. So whenever there is a fracture between this tarsal and metatarsal, it is your Lisfranc. So is Maheshwari enough for the orthopedic questions? See, whatever, they can never be enough for any subject, because medicine or such any subject in medicine is a vast syllabus, right? So whatever book you're reading, just focus on revising that part. So if you can revise Maheshwari thrice, then consider this book as a good book for preparation, right? So here the concept is not perfection, but you have to try to revise that particular whatever notes you have prepared for your exam. You have to revise it n number of times, at least for 3 or 4 times, you know, for you have to remember it for a longer duration. So even if you find Maheshwari is simple, easy for you, and you can revise it thrice before the exam, then please consider that it as a good book. There is no second thought about it. But if you find that you can't read Maheshwari thrice, then again you come down to a book where you can revise it n number of times, right? So revision is the key for the success. Please remember that and try to revise. So prepare notes in such a way that you can revise it. So for example, now I have made this fracture table. So try to put this in your notes or somewhere. You can write them so that you can revise it daily. It takes hardly 10 seconds, right? So what is Chopard's? It's calcaneum bis cuboid and talonavicular. And what is Lisfrank's tarsometatarsal? Cotton's is trimallar, Potts is bimallular, Chopper's is radial styloid fracture, so that you keep revising it. And then that would actually help you more, right, than reading big books. Then what is Sagan's fracture? What is Sagan's is? Sagan's is nothing but it is an indication for ACL avulsion, right? So if you see there is a tibial tubercle in between, the tibial tubercle avulsion, so that is an indication for ACL avulsion or ACL disruption. So that is called your Sagan's fracture. And now let us understand this important table. So this is very, very important. Please mark it as important and keep revising it, because this is where usually we get tend to confuse. See, before table was little easy because usually we keep revising it, but this particular table we tend to forget it, right? It is a volatile one, so it is usually seen in the spine. So now we are dealing with the spine fractures. So what is a burst fracture? So burst fracture is where the completely there is loss of the vertebral body. So vertebral body into multiple parts, right? Multiple small parts, it goes into multiple small parts, that is a burst fracture. So it give it something complete body of the vertebrae is involved, so in burst fracture. So similarly to the name burst, so whenever burst is, there are many fragments, right? So this is complete loss of the vertebral body. If you see the vertebral body, it is a burst fracture, so comminuted fracture of the vertebral body, right? So that is burst. Then what is a chance fracture? So chance fractures is the flexion extension injury where you see a horizontal fracture in the body. So horizontal fracture in the body is a chance fracture, right? And then what is a Clay-Showers? Clay-Showers is again sixth or seventh spinous process which is damaged, right? Involvement of spinous process. You know what is spinous process in the spine? So that is the spinous process which is damaged in case of Clay-Showers, that is sixth or seventh. What is dense? Dense is again important. It is a odontoid fracture. Fracture of odontoid is dense. Then hangman's, you have to remember hangman's is for C2, right? So this is a hangman's is a type of spondylolisthesis over C1. So traumatic spondylolisthesis of C2 over C1 is hangman's. Just remember hangman's is C2. But you always tend to get confused between Jefferson's and hangman's. But it is very easy. You remember Jeff, there is F means first, that is C1, right? F is there in Jefferson, so F is for 1, that is first, that is Jefferson's fracture, and then 2 is for hangman's fracture. Then what is a whiplash injury? Whiplash is nothing but a soft tissue injury, right? So soft tissue injury of the spine because of the hyperextension followed by sudden flexion. So whenever you're sitting in the car and you just met with an accident, you go and come forward like this. So hyperextension and flexion, so that is your whiplash. There is a soft tissue injury occurring in the back which might result in the stiffness, pain, neck problems. You can't bend the neck, you can't, they come with a lot of pain in the neck, but usually the bone is normal, so you have to just convince them it is a whiplash, that is a soft tissue which is involved. And what is undertaker's fracture? So this is a very tricky question. So undertakers is usually a post-mortem injury where the handling of the dead body is not proper. Then it is a undertaker's fracture where you see C6 C7 disc disruption, right? So this is a post-mortem fracture. Usually when the dead bodies are not handled properly, then you result in this undertaker's fracture. So usually they might ask what is undertaker's fracture just to confuse you, but please remember it is after that. And here there are some of the images which I brought for you, so please answer them as A and B and C. So A, I've already told you, that is the burst one. C, if you see, there is an horizontal fracture involving even the posterior aspect of the spine. So this is the chance fracture where the posterior elements are also involved, right? And Clay-Showers, if you see the spinous process, that is C6 and C7 spinous process, whenever it is fractured, it is called the Clay-Showers fracture. Now we are done with the one-liners. Then we will go with the imaged base here. So this is 2 important questions. So what is this fracture? Just shout it loud. What is this fracture? It is Gilesi, right? Galeazzi fracture, where you see fracture of radius with the distal radial joint involvement. And then what is this? Then this is your Montigia, where the proximal ulna, so ulna is fractured with the radial head, right? Ulna with the radial head is your Montigia, and opposite is your Galeazzi fracture, right? Now coming to the pediatric trauma, the usual site of physeal injuries is, so you have to remember the zones of physis, and the hypertrophic zone or the zone of hypertrophy is the area usually the physis gets separated. So that is the weakest part, and this is your zone of hypertrophy, right? You can know first is the germinal proliferative hypertrophy, then enchondral, and the zone of Ranvier. These are the zones which we have. Germinal is the one where you have the reserve cell, so damage to this particular part will result in growth abnormalities, right? So for this you have what is called as the Salter's classification, right? So here in the Salter's classification, whenever it is from the epiphysis which involves the germinal area, the patient results with growth abnormality. But with the S and A, where it is below this germinal layer, there is no problem for the growth, right? And what is the Ranks addition? Ranks has added the perichondrial injury, right? The perichondrial injury to the physis, whenever it relates, it is called Rang, and it is type 6, where the injury is the perichondrial part is also involved. It is called Rang's addition to it, right? Gartland's supracondylar fracture humerus, I have already told you there are three types: type A, type B, and type C. So type A is undisplaced, and type B is mildly displaced, and this is grossly displaced. Just remember these three. So type A, type B, and type C, you see type A as undisplaced, B is mildly displaced, where the posterior cortex is still intact. So this will give the S shape. So the posterior cortex will act as hinge like, and it is still intact in case of type B, right? Type C is completely displaced. The most common osteotomy done to address the malunited supracondylar humerus. So malunited supracondylar cubitus varus, and the most common is your French osteotomy, which is done to correct this malunion, right? So we have to remember it's a French osteotomy, and where you will do a lateral closed wedge osteotomy. So on the lateral aspect, you will open, cut, and then you close it. So this is the French osteotomy. Tardi ulnar palsy is a union of lateral condyle humerus, right? Lateral condyle humerus is the tardy ulnar palsy, right? So whenever there is a lateral condyle which is not uniting, and there is a increase in this medial condyle, will result in this tardy ulnar palsy, right? And then treatment of choice for shaft femur of less than 5 years of age. So here in this case you can go for what is called as hip spica. So usually less than 5 years age, you go for hip spica. If it is a neonate or something like that, you go for Pavlik hernias is one usually given for the infants, or just born babies, infants, and 1 to 2 years. But less than 5 years, from 2 to 5, you can try for hip spica. So what is a spica? So you complete limb, and then with your pelvis, and then half of this limb is your spica. So whenever you're involving the abdominal part into the plaster is called spica. So now you put the entire limb into it, and then you will go put the abdomen, part of abdomen in, and sometimes it extends to the half of your contralateral limb too. Toddler's fracture is seen in tibia bone, right? So this is the toddler's fracture, usually we see in tibia. And now let's little about the arthritis. So percentage of neutrophils. So synovial fluid is very important. So what is the average of, what are the contents which are present in the synovial fluid? Usually there are no RBCs which are seen, and WBCs are usually seen. Synovial fluid, somewhere it is about 25% of neutrophils which are seen, and if this number has increased, it is a indication of infection, right? So this is how you have to deal with the synovial fluids, and you will see that if it is a clear, and if it is a yellowish, then it is a normal, but it is filled with red blood, or red blood cells are present, or if the neutrophils are more than 75%, and the cultures are positive, then it is a sign of infection, right? In WBC, in inflammatory also, there is an increase in the lymphocytes. So in case of TB, you will see increase in the lymphocytes. In case of bacterial, you will see increase in cells. right? So this WBC somewhere around 2000, right? Normal. So somewhere more than 2000, it is inflammatory, right? If it is more than 10,000, it is. So that is how you have to remember regarding the synovial fluid. And what are the three cardinal features which you see on the X-ray of an ONE? So that is a joint space narrowing, subchondral sclerosis, and most important thing which you see in case of degenerative arthritis is the osteophytes, right? So these osteophytes are one clue which tells you that you're dealing with a degenerative arthritis. If it is an inflammatory, usually you don't see osteophytes, you usually see this joint space narrowing with subchondral sclerosis in case of inflammation. But when you see a lot of osteophytes present around it, that means you're dealing with osteoarthritis, that degenerative condition, right? And coming to inflammatory, that is rheumatoid arthritis. Rheumatoid arthritis, where what you see, the small joints which are usually spared in rheumatoid arthritis is the distal interphalangeal joints. So in case of rheumatoid arthritis, usually again there is a joint space narrowing, but it is usually bilateral narrowing is seen. But in ONE, you see a joint space narrowing, which is mostly the medial compartment, because the weight bearing axis passes through the medial aspect, so there is a medial degeneration which is seen. And in case of relative, that is inflammatory, you see bilateral joint space narrowing, that is both the medial and the lateral compartment is present, and you see not much of osteophytes which are present, like but sclerosis is also seen in your rheumatoid. But the joints which are most commonly involved in rheumatoid are the wrist joint and your MCP. Then there is involvement of your PIP also, but the DIP are usually spared in case of rheumatoid. But the most important thing in OA are the DIPs. So DIPs are also involved in your osteoarthritis. What is the drug of choice in patients with RA? Methotrexate. So this you all know, that is the DMRDAs, that is which you usually use, and it is dwelt a lot in case of medicine, that is your methotrexate, right? So 10 to 15 milligrams per kg dose management you do, and you give the first choice is methotrexate. What is the antigen marker? This is also an important question. It is HLA-B27. It is just a one-liner, that is HLA-B27 is the marker which is usually used for ankylosing spondylitis, right? And then comes the earliest X-ray features in ankylosing spondylitis are seen in which joint? You already know that this is the sacroiliac joint, which is usually first involved in case of ankylosing spondylitis. So you should always evaluate for the sacroiliac joint and then go for the spine, and then you see mostly in the young males with the HLA-B27 positive, right? So these are the characteristics of the ankylosing spondylitis, right? And then we have done with arthritis. Then we are going to the metabolic conditions. The main constituent of the unmineralized matrix of the bone. So if you remember the matrix of the bone, again you have to go in deep, that there is organic and inorganic, right? And now in inorganic you have a lot of minerals which are present. Inorganic, it is collagen. So the unmineralized matrix is mainly the collagen, right? So the main constituent of the bone is the collagen. First the collagen is spread. On top of collagen you see your inorganic minerals, that is your calcium and the phosphorus gets deposited. So the calcium and phosphorus get deposited on the collagen, which is the unmineralized matrix. What is the investigation of choice to measure the bone mass? This you all know, the DEXA. So to the measure the bone mass is usually the DEXA scan which is used. This is nothing but the dual energy absorptiometry, that is X-ray absorptiometry, where it is a form of X-ray but with the low radiation, right? So this DEXA is usually done, and you can evaluate your calcaneum or your hip or your vertebrae, and based upon the DEXA scan the bone mineral density is calculated. That's BMD, and you have less than 2.5 of BMD is your osteoporosis, right? So that is the investigation DEXA scan. Most common site for osteoporotic fracture. So once we are dealing with DEXA scan, usually we treat with bone marrow disease, that is bone mineral density. And here the most common site is the vertebrae, right? So vertebrae, but usually commonly on a practice we usually see it in the wrist, right? So a little bit tricky, but usually in textbook quoted or theory, it is vertebrae fractures which are most common osteoporotic, and but clinically usually many cases we see the wrist fracture, right? And then one more important is your hip, right? So these three are important to evaluate in case of osteoporotic females, right? So the vertebrae should be evaluated, the wrist and the hip. The most common site is vertebrae. Earliest bone change in rickets in case of infants. So what is rickets? Rickets is there is a decrease in vitamin D, right? So vitamin D in children, whenever it is low, it's called rickets, and in adults, it osteomalacia. In infants, it usually presents with what is called as craniotabes or the ping pong mechanism of the skull. So craniotabes, you press like the ping pong ball. So this is the most earliest change which you detect in case of rickets. X-ray used to screen for rickets. So once there is a 5-year-old coming to you and with lot of complaints of pains here and there, and you want to evaluate for rickets. So what is that one X-ray which you order for? Very good. That is the wrist X-ray which you take, and this wrist X-ray you can evaluate for your features such as cupping, fraying. So these all can be seen on the wrist X-ray. So the screening for rickets is usually the wrist X-ray which we see. Inheritance in familial hypophosphatemic rickets is X-linked dominant is the most common which is inherited. So coming to the hypophosphatemic rickets, it is the one condition where it is resistant rickets. So usually rickets be treated with vitamin D and calcium, but even with that you find some difficulty in the treatment because of the resistance to the oral vitamin D. So here the inheritance of the familial hypophosphatic rickets is mainly X-linked dominant. There are various varieties in it. So you have to understand in detail about hypophosphatemic rickets, right? So this is the area where the phosphate deficiencies, FGF fibro-growth factor 23 is deficient. So this inheritance is mostly through the X-linked dominant. Next, osteitis fibrosa cystica. This is very important. It is mainly seen in your hyperparathyroidism, right? Hyperparathyroidism. Hyperparathyroidism, where you see there's a lot of demineralization of the bone is taken. So they because of PTH is increased. As you already know, there is an increase in PTH. This PTH is in love with vitamin this bone, so it increases the calcium. So this calcium is taken. So osteitis fibrosa cystica is such area where you find this as tumor, right? So now the blood gets deposited in here and gets calcified. So this is resulting as fibrosa cystica. So this is seen in your hyperparathyroidism. Next, what is Paget's disease? Paget's disease is usually seen in elderly, right? And the drug which is most commonly used here is the bisphosphonates. Bisphosphonates is the drug which is usually commonly used for the treatment of Paget's. I hope you're all well versed with what is Paget's disease. And now coming to the pediatric, one more thing. The mainstay of clinical examination of the DDH in newborn is, this is very, very important, the Barlow's and the Otterlany. So, Barlow's and Otterlany, you know what is the clue for it. Barlow, right, making the hips outside, and Otterlany is putting them back into the hip. So Barlow's and Otterlany are the main clinical examination or the screening which is done for DDH. So if any newborn which is born out of breech position, firstborn female, breech presentation with other congenital malformation, want to screen for DDH, then you have this test which is called as Barlow and Otterlany. Barlow is already this hip which is there inside you are bringing out, and if it is easy for you to bring it out from the tabulum, that means it is a developmental dysplasia which is. Now what is this? If you have done this Barlow's and Otterlany, and now if it is DDH positive, then what do? You treat that with Pavlik harness. So the orthosis which is used is the Pavlik harness, right? Herring lateral pillar classification. So herring lateral pillar classification is one such which deals with one important condition, again, is your Perthes. So what is Perthes? It is avascular necrosis of your femoral head, right? So there is some a problem to the vascular supply usually seen ages of 4 to years because of devoid of the vascular blood supply. head, it results in what is called as avascular necrosis, and this is called as Perthes. And for that, you use this later pillar classification, which is called the Herring's classification. Now, so we have done with DDH, Perthes, and next important thing which you are going to deal is SCFE. What is SCFE? Slipped capital femoral epiphysis. So in this slipped capital femoral, usually the clue would be a fat, that is the obese, usually the males, with the endocrinopathies. So this endocrinopathy, when they are dealing with, and now with trivial trauma, with the trivial trauma, they will be slip of this epiphysis, right? So there is a posterior medial slip of the epiphysis, and then they come with lot of pain. That pain is usually radiating to the knee. So usually they present with knee pains, and you deal with a lot of analgesics, and then you evaluate. That is, again, you have to remember that one joint above, one joint below, right? So once the patient complains with the knee pain, you have to always evaluate for the hip movement. So here there will be some abnormality in the rotations of the hip, and then you take the X-ray, you find that there is a slip of this epiphysis, and now you diagnose that particular individual as SCFE, and you tend to see that is a stable slip. And how do you treat it? Usually we do what is called as in situ pinning, right? So stable hip are treated with, so this is called as SCFE. So fat males endocrinopathies with trivial trauma complaining about pain more in the knee, the radiating pain from the hip to the knee. These are the clues for your SCFE. So varus in CTV. So CTV is another important question. So varus is usually seen in case of the calcaneum. So the calcaneal varus. So the hind foot, usually the hind foot, it goes to varus, right? So this is also one of the important topic which you have to remember, CTEP, right? And then the treatment of choice for idiopathic clubfoot in a neonate. So it is usually Ponseti method which you deal with. So Ponseti method. So that you have to remember that there are various deformities which occur in the foot, right? So what are the deformities? Remember it as cave, right? You will remember it as cave. So you start with equinus, varus, adduction, cavus, right? So cavus, adduction, varus, and equinus. Equinus is where the foot, the plantar flexion, and the varus occurs in the hind foot, adduction in the midfoot, cavus again in the midfoot. So this you can put adduction as a forefoot because the metacarpals get adducted. The cavus is the mid-tarsal goes into cavus, and the varus is the hind foot which you see, and the equinus is the ankle, right? The tendoachilles fracture that goes. And now how do you correct them? You have to correct them in the same order, that is CAVE, and this was given by the famous Ponseti, and you always use the Ponseti method for correction, right? And what is the most common surgery which is employed here? You have to always remember that the posterior medial soft tissue release is one of the common procedure which is usually employed. Because the word surgery has been used, I have used the PMSR, but another one is just a Z-shaped incision which is given to lengthen the tendoachilles. So lengthening of tendoachilles is one important procedure which you do, but this is done in the OPT based. But the PMSTR, that is the posterior medial soft tissue release. Just remember that the CTEV or the whatever the deformities you see in the foot are because of this contraction on the posterior medial aspect of the soft tissue. So hence you go for a posterior medial soft tissue release. So that is about the EV. Now quickly let's go through these images. So here you see, as I told you, there's exlopticity. I told you one more important fracture, that is the mesonevis fracture. So this is your mesonevis fracture where there is a disruption in the ankle. So this is your ankle fracture. So you see this line and this line are not together, right? So that means there is a gap. So there is some disruption, some abnormality. So this is a syndesmotic fracture which is happening there. And now if you see the upper, that is the knee joint, you see there is a spinal fracture in the proximal fibula. So this is a mesonevis fracture. And then what is this? So this again, if you remember, we have already dealt, the tarso-metatarsal area is involved. So this tarso-metatarsal area when involved, this is nothing but your Bliss Frank injury. So So list flank injury. So whenever there is a gap between your first and second metatarsus, this increase in the gap is indication for your list flank, right? So this angle. So what is this angle? So in the ankle, so there are two important, not in ankle, sorry, in the calcaneum. So whenever you're dealing with the calcaneum fractures, you have two important angles you have to remember. So one is your Bowler's angle and then your angle of Gisane. So this shows the Bowler's angle, right? And then what is angle of Gisane? So this is your angle of Gisane, right? So these are the two important angles. So one angle, Bowler's angle, and the angle of Gisane. These two are seen in case of your calcaneum fractures. And after fixing the calcaneum, you have to deal with these two important angles. So again, what is this important attitude? We have dealt so much. This is your father. So flexion, adduction, and internal rotation. So once you see there is a flexion of the hip here, and there is adduction, and then there is an internal rotation, right? So this is the internal rotation which you see. So this is the father which is seen in case of posterior dislocation. And what is this X-ray? Suggestive of your green stick fracture. So there is only involvement of one cortex. The opposite cortex is intact. So this cortex, if you see, is intact. So now you see the cortex. So now you see the cortex. This cortex is intact, and then this is your green stick fracture, right? So next is your torus fracture. So this is buckling. If you see here, there is a buckling. So this is your buckling, which is, so this is the torus fracture, usually seen in pediatric bones. So green stick and the toddler. So just buckling of the cortex is called a torus fracture. So now I've told you about the Perthes disease, right? So Perthes disease was what? Avascular necrosis of femoral head. So similarly, we have various avascular necrosis of various bones, right? So that could also be an important question. So in case of avascular necrosis, in case of lunate, it is called as Kienbock's disease. So how do you remember? Kienbock's, key and lock. So key and lock, Kienbock's is for lunate, right? Calcaneum, Sievers is calcaneum. Sievers is calcaneum. Usually, I remember this as a product called shell cal, right? So we usually prescribe the supplements of calcium as shell cal, right? So S and C. So it is like Siever and cal, right? So shell cal, that is how I remember. Then next is scaphoid. Scaphoid is Precer's disease. So this I could not come up with any clue. So this is a Precer's disease is scaphoid. Next, second metacarpal head. So this is Freeberg's. Freeberg's is second and Eislin's is fifth. Eislin's is fifth metacarpal, right? Fifth and Sleene. Eislin is fifth metacarpal. Ring epiphysis of vertebrae. This is Scheuermann's disease, right? Scheuermann's disease is ring epiphysis of the vertebra, and then you have navicular. Navicular is little easy. I remember this as the Virat Kohli, right? So Navi and Kohler's. Kohler's disease is navicular bone, right? So Virat Kohli, that is how I remember. And then capitulum of the elbow, that is Panner's. So it is the, how I remember this as the pan card. So pan and card. So Panner's is capitulum, and next is your Virat Kohli, the famous cricketer. So Virat is Kohler's, right? And then Kienbock's. Kienbock's is lunate. So this is lock and key, right? Lock and key, Kienbock's. And calcaneum, I told you, that is shell cal. That is Sievers and calcaneum is shell cal. And now you have to remember the Freeberg's as second, Eislin's as fifth, and Precer's as scaphoid, right? So that is how we remember the avascular necrosis. And what is this deformity? This is the swan neck deformity which you see. You see in case of rheumatoid arthritis, right? This is the swan neck deformity where there is a flexion of the DIP, extension of the DIP. And what are these? This is also important question. Mark this as important. And you can see the dagger sign. What is the dagger sign? So this is the dagger sign here. So this is the dagger sign, and this is the bamboo spine where the bamboo is completely in the single thing, right? It is seen as a single one because of this syndesmophytes. Now you can see the X-ray clearly. I have erased everything. So now this is your daggers and this is your bamboo spine where the syndesmophytes are formed. And where do you see this? This is an important condition which is called as ankylosing spondylitis. So this is an images for ankylosing spondylitis where you see the dagger sign and the syndesmophyte bamboo spine. And what is this? So this, as soon as you see this particular first metacarpal involvement, involvement, MTP joint, this is your gouty arthritis. So this is gout, and here you see what are called as tophi, the deposition. The depositions, the urate depositions over the joints, this is called the gout involvement of the first MTP. And now what are the various changes you see? So you see the fraying here, the cupping here. So there is a cupping, fraying, right? So what is a cup-like formation here? This is cupping which you see, and this is the fraying. The extension is the fraying, right? So this is the rickets. So a widening of the physis. So you see there is a large physis, widening of the physis with the cup-like formation, the fraying, and these are all which are seen in a common deficiency, that is the vitamin D, which is called as rickets, right? And what are these? These are the fractures which we see. So this is the loser's zone you see in osteomalacia, right? So osteomalacia, loser zone. This is again curvy. What is curvy? You see bleeding gums with these type of, hematomas into the joint because of the bleeding into the joints. This is nothing but was curvy, right? And what is this? Here, if you see the GT here and the GT here, there is a proximal migration of the GT, and we all know that we can draw the quadrants. So one line along the Hillingren's line and one along the lateral border of the acetabulum, that is the Perkins line. So this is Perkins, this is Hillingren's, and here similarly you draw Hillingren's and the Perkins. Okay, let me draw it little. So now what you observe it? So here you observe there is some abnormality in the presence of the femoral head. So if you say this is outer quadrant, inner quadrant, upper quadrant and lower quadrant, right? So this is, you see this femoral head in case of lower and inner, and here you see outer and upper. So whenever this particular head is present in outer and upper, this is an indication of developmental dysplasia of hip, right? DDH. DDH is where the line is drawn along the Hillingren's, that is H, triradiate cartilage, and the lateral aspect of the acetabulum is Perkins line. And now you see the femoral head outer and upper quadrant. So that is DDH. Usually this is normal where you see outer and inner and lower, right? And what is this? This is Dennis Brown splint. So DB splint or the Dennis Brown splint, usually used in case of CTEB. So once you put this Ponseti casing is done, and then the deformity is corrected. Now you have to maintain this, no? So while maintaining, you give this what is called as DB splint, where the patient has to wear up to 5 years, right? And what is the type of non-union? So non-union is one where there is no union without intervention. So now the bones have to heal, right? The bones have to unite. But if there is some problem in the union of the bone and it needs help from the external sources, then that is called as non-union. Here if you see, there is a lot of callus which is formed, right? But there is no stability. So this union of the bone depends upon two important things. So one is the mechanical stability, and the second one is the biological environment. So mechanically you give stability to it by the implants or the fixations which you do, and biologically you have to provide the environment which you do it by the bone grafting. That is, you put bone that will stimulate the new bone. So that is bone grafting. So here you see lot amount of callus. So this is three types of non-union where you see lot of callus. This is called as hypertrophic non-union. And then you see what is called as atrophic, where there is no callus at all. So there is no callus, and in between you see what is called as oligo, right? So here you see a lot of callus. So what type of non-union exactly? So this goes into a hypertrophic non-union, right? So what do you do this? Hypertrophic is where the biology is correct. So biology is correct. I mean, there is a lot of callus which is forming, but it doesn't know what to do with that callus. That is, there is no stability to it. So now you provide some sort of stability, some sort of mechanical support to it, then it will heal. So that is a hypertrophic. Whereas you go for atrophic. Atrophy is there is no proper callus. That means it is weak in biology there. So there is no formation of growth. There is no growth. So there are no reserve cells or things which increase the growth of the bone. So there you put something which is nutritious to the bone, so that you give the bone grafting. So graft, the bone graft, when you put it is, there are types of bone grafting that you do with osteoinductive, osteoconductive, that is few elements which induce the bone formation, few elements which act scaffold for the bone to form. So there are various types which can be used. So that is how you increase the union of the bone, right? And now what is this? So there is something, the lady has done something, that is this is nothing but your shopping cart which is using, and on usage of the shopping cart, the pain has decreased. Here she is having pain, so this is a shopping cart sign, right? So here this is seen in your lumbar canal stenosis, where flexion of the spine will decrease the pain, right? So now as you extend, your spine becomes straight, the whatever the spaces are there, it becomes a little narrow, and then they cause impairment of the nerve. Now you try to bend a little, now they open up, and now the pain is reduced. So that is the shopping cart sign which is seen in your lumbar canal stenosis. Now what is the nerve which has been tested? This is your cart test, and this test is used for your ulnar nerve palsy. So this is the ulnar nerve palsy. So this is the cart test which we are dealing with. So you test for your the muscles, you know, the lumbricals which are present there, and now basically you test for the adduction of the fingers. Now what is this? This is the Kopp's angle, right? So what is a Kopp's angle? Now this is the scoliosis, and you have to know about the angle of the scoliosis. So for that you use a method which is called as Kopp's method. That is Kopp's angle you measure. That is, now you take this curvature, and now you identify that apical vertebra where the vertebral lines are little parallel to each other. So that is the apical vertebra, and you draw line according to it and perpendiculars to it. So this is the line according to it, that is the apical vertebra, and then you draw perpendiculars to this. So now this is the scoliosis angle. Less than 20 degrees of scoliosis, no treatment, only observation. 20 to 40 degrees, again you treat it with the orthosis, and more than 40 degrees of scoliosis, you go for the treatment or the fixation. So that is how the angle is important for you, and this is called the Kopp's angle. And now what is this baby wearing? So this is called the Pelvic harness. So Pelvic harness is one which is used for treating the DDH. So less than 6 months of age, you go with this type of DDH, where it gives the external rotation of the hips, so that the hips sit into this acetabulum. Okay, now this was asked in the recent NEET PG. So this is the interosseous membrane, membrane method of fluid resuscitation, right? So now you go for in our children, in pediatric population, in children, usually whenever there is, you know, some problem of giving of IV fluids with the peripheral lines, and you can go for this method, right? So this is the infusion, that is IV fluids are given through the process method of infusion, right? Next, similarly, because that was asked, I have just picked up this little picture. So this might be a potential question. This is the where the pressure, some device is being used for the wound here. So this is nothing but your vacuum assisted closures for the wound. So this is called simply as vac. So vacuum assisted closure. Now we put the pressure, and now we drain the fluid continuously, suction continuously, so that the granulation tissue is formed, and this tissue will heal the wound instantly. This is the vac which we use. And now this is the pelvic binder, which I have already told you. So this is the pelvic binder which used to close the rings of the pelvis. And what is the test here we are doing? This is straight leg raising test. So this is a passive test which the examiner is doing, and this is to evaluate for your disc pathology. So whenever there is a disc pathology or the sciatic nerve involvement on raising the limb straightly will result in stretch of the sciatic nerve and will produce the pain. If patient is in pain at 60 degrees or less than 60 degrees, that means there is involvement of the disc. The disc will bulge out and will compress the nerve. So that is a passive assessment. And what is this arrow pointing at? This is sequestrum. Sequestrum is a dead bone, but this is sclerotic, is highly dense. Why sclerosis? Because there is no blood supply to it. So that whenever there is no blood supply, there is no demineralization of the bone, right? So now this will result in a dense sclerotic bone which is surrounded by a lucens. So that is your sequestrum. And what is this? This is a large amount of, whatever the new bone is formed, which is called the involucrum. So this is the involucrum where the large amount is formed, right? And what is this implant? This is prosthesis. So this is the replacement of the anatomical structure in the bone. This is the prosthesis, replacement of the anatomical structure. So what structure it is replacing? It is replacing the femoral head, right? Femoral head and neck. So whenever there is an IC fracture, you want to remove that head because subsequently the head goes into avascular necrosis. So now for that you have to put the head and neck into it, right? So this is the prosthesis which we use. So here we go for Moore's prosthesis. So if you see two holes, two O's, and then there's a collar, that is Thompson's. So this was used 10 years ago. Now we have shifted to the bipolar prosthesis. So now we are only using the bipolar prosthesis, right? So this was Morse and this is Thompson. Whenever you see a collar, then that is Thompson. Please remember the collar is for Thompson. Now what is this instrument? So this is the osteotome. So osteotome is one which is used to cut the bone. I mean, you can this is very sharp. Chisel is little blunt. This is the osteotome which is very sharp, and now you do the osteotome, that is will cut the bone with it. Whenever you want to do a bone grafting, you want to remove piece of the bone, or when you want to remove the part of the bone, and you can do the osteotomies. So for that you use this osteotome which is sharp here, right? Sharp, and this is the osteotome. And nerve injury, there is neuropraxia, right? Axonotemesis and neurotemesis. Axonotemesis and neurotemesis. So neuropraxia is just a concussion injury or just a flow is being stopped. That is neuropraxia. And then you have neurotemesis. Neuropraxia is where there is a conduction block. So whenever there is a block, it is a neuropraxia. And axonotemesis is when there is a disruption of the myelin sheath, but axon is intact, right? So axon is intact, and whenever there is a disruption of the myelin sheath, is axonotemesis. Neurotemesis is completely cut off that particular nerve, and the regeneration is not easy. So there is no regeneration in case of neurotemesis. And what is this? This is Erb's palsy. So Erb's palsy is one which involves the upper trunk of the brachial plexus, where you can see a policeman tip deformity. And what is the splint? This is splint is nothing but your cock-up splint. So cock-up splint is one which is used for your wrist drop, right? So wrist drop is one thing which is usually seen in case of radial nerve injuries. So there is loss of extension and of the wrist and the fingers, and this will result in the wrist drop. So for supporting the tendons, you have to use this cock-up splint, and this is a static cock-up splint, right? So this is a static cock-up splint. And what are these areas which are supplied? So this is the radial nerve for pink, right? And median nerve for blue, and green is for ulnar nerve. So this, please remember these three, and these are very specific for radial, median and ulnar, and any question related to this you can solve with this particular image, right? As you already know that the muscles which are supplied, this is the skin supply. And now we have come to the muscle supply, that is this is the claw hand. So there is a flexion of the fingers with extension of the MCP joint. So there is an extension of the MCP. This is the claw hand usually seen in ulnar nerve. palsy. So there is an ulnar nerve palsy which is seen, that is your claw hand, right? And now let us deal little bit of trauma, a little bit of tumors, and then so the what are the radiological signs in case of osteosarcoma? Usually in tumors they ask about the radiological signs. So in osteosarcoma you see what is called as the Codman's triangle, right? And then you can see the sunburst appearance, right? And then you see giant cell tumor. It is very simple. That is, it's also called as osteoclastoma or the soap bubble appearance, right? So bubble appearance is seen in case of your osteoclastoma. Then fibrous dysplasia, the shepherd crook deformity, which was asked recently, right? The shepherd crook deformity is seen in case of your fibrous dysplasia. Ewing's sarcoma, which is usually seen in the diaphysis, and it is the onion peel appearance. That is the, what is this onion peel appearance? The periosteal reaction. The periosteal reaction is the onion peel appearance. Then chondrosarcoma is the calcifications which you see. The popcorn calcification is the chondrosarcoma. Simple bone cyst is like a lytic lesion, and whenever this is associated with the fracture, you see a fallen leaf sign, right? The fallen leaf sign is seen of simple bone cyst, and multiple fluid levels is in case of aneurysmal bone cyst. Multiple fluid levels in case of your aneurysmal bone cyst are some of the radiological signs. And next, last one and very important is this particular table, the sports medicine. And let's quickly fill up this, and this is the last slide. So anterior drawer test, faster, ACL. Posterior drawer test, is for your PCL, right? ACL and PCL. Then pivot shift is again for your ACL, and this is somewhat very specific for ACL, right? And then Apley's grinding test is for your again your meniscus, and then McMurray's is for your meniscus again. So you have to test for McMurray's, medial meniscus and lateral meniscus. Apley's is again for meniscus. Varus and valgus test. So this is for MCL and LCL. So varus is for LCL, the lateral collateral ligament, right? And the varus is for MCL. So varus and valgus is for MCL and LCL. Then you have empty can test. The empty can test is for supraspinatus, right? And the belly press test. So LCL, and then you have MCL. Then empty can test is for supraspinatus. So this is your empty can. So you put like this, abduction, right? And you go and you try to lift your limb, right? This is the abduction you put, and then you try to lift your limb up. This is called empty can test. And belly press is for your subscapularis, right? And drop arm sign is again for your supraspinatus. So drop arm sign, so patient is unable to maintain that arm in that particular position, so that is the drop arm sign which you see, that is for your supraspinatus. And then your lift off test is for subscapularis. So supraspinatus, drop arm sign, and lift off test is again for your subscapularis. So lift off, you put internally rotate like this, and then you try to lift it up, right? So that is subscapularis. Yugas and Jobs and apprehension, these are all for your shoulder dislocation. Shoulder dislocation. So Dugas test is nothing but touching the opposite, right? There is a Dugas test. Jobs test and apprehension is for your recurrent shoulder dislocations, which we do, right? And finally, the Thomas test is for your fixed flexion deformity of hip, right? So that we come to the end of the session, the sprint. I hope I was faster for some time because I need to complete, and hope you're all benefited from the session. And now these are the coming up the FMG test which we are planning to conduct. And always remember, the practice makes man perfect. So you have to always practice, keep practicing. Don't try for perfection in any subject. So you keep on revising the things. So for that you have to attend the grand test, keep writing the grand test, and see the areas of your, whichever areas you're weak, and then try to work on it, right? So wishing you very all the very best in your exam. Hope you all come out with the flying colors. Thank you so much for your patience. Thank you.